Good day guys, this is Dr. Rahulism here. In this topic we'll study about hypothyroidism, its clinical features, pathophysiology, diagnosis and treatment. I will guide you through the whole topic. So we'll start with the introduction to hypothyroidism. So what is hypothyroidism? Guys, as we know, thyroid glands secrete the iodine containing hormones in our body called as the T4 and T3. T4 is called as the tetraiodothyroid and T3 is called as triiodothyroid. So only 25% of the T3 is secreted by the thyroid gland. So the rest of the T3 is actually converted from T4 into T3 by a process called deionization. So the active form in our body is T3. So hypothyroidism can also be congenital or acquired. So as I told you already, the most common cause of hypothyroidism is Hashimoto's thyroiditis, and it is autoimmune disease. So hypothyroidism is actually more common in women than men. So next we'll study about the etiology or causes of hypothyroidism. So there are various causes, but we'll start with the primary cause, which is the primary hypothyroidism. So this is a condition where the thyroid gland produces insufficient thyroid hormones. So as we discussed already, Hashimoto's thyroiditis is the most common cause of hypothyroidism worldwide. So it is an autoimmune disease. So this is associated with the gene HLA-DR3 and also other autoimmune diseases such as type 1 diabetes mellitus, pernicious anemia, and it could also be SLE. So there are other forms of thyroiditis such as postpartum thyroiditis, and the cause could also be iatrogenic. The patient could have acquired this hypothyroidism from the hospital post procedures, and it could also be nutritional when the patient takes less iodine supplement or the due to the insufficient intake of iodine, and this is the most common cause of hypothyroidism worldwide, especially in iodine deficiency regions. So the next cause is thyroid dysplasia. So the thyroid dysplasia is a condition where it is a disorder of embryologic development, where it is characterized by abnormal development or location of thyroid gland. For example, lingual thyroid. So lingual thyroid is a condition where a rare abnormal mass of ectopic thyroid tissue is actually developed at the base of the tongue. So the next cause is secondary hypothyroidism and tertiary hypothyroidism. So in case of secondary hypothyroidism, it's related to pituitary disorders such as pituitary adenoma. So as we know already, the pituitary gland secretes TSH. So that is responsible for stimulation of T3 and T4 in the thyroid gland. So any disorder related to pituitary gland could also cause a hypothyroidism, and that is termed as secondary hypothyroidism. And the final one is tertiary hypothyroidism, where the hypothyroidism is linked with the hypothalamic disorders. So as we know, the TRH is secreted by the hypothalamus that stimulates pituitary gland to secrete TSH. So any disorders in the hypothalamus can lead to tertiary hypothyroidism. So next we'll discuss the pathophysiology of hypothyroidism. So starting with primary hypothyroidism, as we discussed, the primary hypothyroidism is actually where the thyroid gland produces less T3 and T4. So either the T3 and T4 are not produced, or it results in less T3 and T4 production or insufficient thyroid hormone production. So that leads to the decrease of T3 and T4 in the blood. So that results in the compensatory increase of TSH levels that causes primary hypothyroidism. And the next one is secondary hypothyroidism. So as I told you already, the pituitary gland secretes TSH. So any disorder caused in the pituitary gland leads to the decrease of TSH levels in the body, and that results in decrease of T3 and T4 levels that causes secondary hypothyroidism. And the third one is tertiary hypothyroidism. The tertiary type hypothyroidism is a condition where the hypothalamus secretes decreased DRH levels, or any disorder in the hypothalamus leads to the decreased stimulation of TSH as well in the pituitary gland. That results in the decreased production of T3 and T4 levels that causes tertiary hypothyroidism. So next we'll study about the effects of hypothyroidism in our body. So starting with the first effect, so there is a decreased basal metabolic rate of our body. As we all know, the most important function of thyroid gland is to regulate the basal metabolic rate. So because of the decreased basal metabolic rate, there is a decreased oxygen and substrate consumption, as a result of which there are disorders of central nervous system as well, such as apathy and slowed cognition. Coming to the skin, the patient has a cold skin, cold intolerance because there's decreased blood flow, and the patient has alopecia, which is nothing but the hair loss. So the next effect is a decreased sympathetic activity. So coming to the sympathetic activity, we all know the thyroid hormones interfere with the sympathetic nervous system, as a result of which there is a decreased sweating, and the patient has constipation because of decreased gastrointestinal motility, and also the patient has bradycardia. And coming to the decreased transcription of sacrolemmal genes, we got to know what is sacrolemma. So we all know a myocyte. What is a myocyte? A myocyte is nothing but a muscle cell. So a cell membrane of a myocyte is called a sacrolemma. So because of this decreased transcription, the patient has a decreased cardiac output. So that results in cardiomyopathy in the patients with hypothyroidism. So the next one is hyperprolactinemia. So coming to the hyperprolactinemia, we all know that TRH, which is secreted by the hypothalamus, is responsible for the stimulation of TSH in thyroid gland, as well as stimulation of prolactin in pituitary gland. So because of hyperprolactinemia, there is a suppression of follicle stimulating hormone, LSH, and gonadotrophin releasing hormone, and also testosterone. That results in an increased breast tissue growth, which is nothing but the gynecomastia in males. So, and also the patient has myxedema. So about the myxedema, we already discussed in Graves' disease, which is due to the deposition of glycosaminoglycans and hyaluronic acid. So that results in pretibial edema, we all know. But in hypothyroidism, the patient also presents with the periorbital edema due to generalized mixed edema. That is the most important effect. So the patient and with the hypothyroidism presents with generalized mixed edema. But in hyperthyroidism, the patient presents only with the proximal, which is anterior or lateral mixed edema, pretibial mixed edema. So, but in hypothyroidism, the patient has a generalized myxedema. So that myxedema progresses as the condition of hypothyroidism increase. The generalized myxedema also increases. So this edema is non-pitting edema. So next we'll study about the clinical features of hypothyroidism. So what are the clinical features? So there are symptoms related to the decreased basal metabolic rate. So the patient presents with fatigue and decreased physical activity because of decreased basal metabolic rate. And also, as I told, the patient presents with the cold intolerance, hair loss, so-called alopecia, which is called as the Queen Anne sign. So the patient presents with brittle nails, cold and dry skin. The patient has weight gain despite decreased appetite. The patient presents with weight gain, and also the patient presents with the constipation, bradycardia, and also I told you that a hypothyroid myopathy because of the decreased transcription of sacrolemmal genes. So the patient presents with myalgia, hypothyroid myopathy, and hypothyroid cardiomyopathy as well. And the patient presents with stiffness and cramps. So the most important sign in hypothyroidism is called as the Waltman sign, where the patient has the delayed relaxation of a deep tendon reflexes. So this delayed relaxation of deep tendon reflexes, it actually increases with the age. So the patient also presents with entrapment syndrome such as carpal tunnel syndrome. So the next clinical feature is due to the symptoms related to hyperprolactinemia. So what are the symptoms the patient present with related to hyperprolactinemia? So the patient has an abnormal menstrual cycle, either it could be secondary amenorrhea or menorrhagia, and also the patient has galactorrhea. The patient presents with a decreased libido. In case of females, they have decreased sexual activity, and a decreased desire towards sex. And the patient, in case of males, the patient presents with erectile dysfunction and infertility. So the next symptoms related to generalized myxedema is a duffy skin texture, and you also the patient has the puffy appearance, and the patient presents with a dyspnea, bradycardia, dilated cardiomyopathy. The patient has a hoarse voice, and the patient has difficulty in articulating words. As I already told you, the patient has pretibial and periorbital edema, and finally the patient presents with mixed edema coma. So the pictures here represent the typical picture of the typical representation of pretibial as well as periorbital edema and mixed edema coma. So the next one is diagnostic approach. So at first we'll evaluate the blood test. We'll run some lab tests. So in order to evaluate a TFT, so the TFT shows the if the TFT shows the elevated TSH, so we are sure that it's primary hypothyroidism, because either the T3 or T4 will be low, or the T3 and T4 will be normal. So just in case if the T3 and T4 is normal, or if the T3 and T4, I mean if the values of T4 abnormally high, so we'll evaluate free T4. So elevated TSH represents primary hyperthyroidism. So if you have abnormal TSH values in your patient's blood results, you evaluate further levels of free T4. So the further investigations include thyroid antibody testing in order to rule out, I mean, to find the exact cause, which if the patient has the autoimmune thyroiditis, or you also have the imaging such as ultrasound, CT, or MRI in order to evaluate the thyroid nodules, or just in case of any malignancy. In order to evaluate the malignant infiltration, we rule out, we do CT and MRI for further investigation. So when we measure TSH, it could be either normal, it could be high, could be low. So if the patient has normal TSH, the patient the patient unlikely has a hypothyroidism. So just in case, we'll consider two conditions where the TSH is high and the TSH is low. So if the TSH is high, the patient has primary hypothyroidism. If the TSH is low, the patient has secondary hypothyroidism. So the secondary hypothyroidism, in the sense, the problem is related to the pituitary gland. So when the TSH is high, we have to evaluate the levels of free T4. So if the values of free T4 is normal, it is called as subclinical hypothyroidism. So the free T4 level will be normal, but the TSH level will be high. If the free T4 level is high, it is called as primary hypothyroidism. So coming to the low TSH levels, you evaluate the free T4 levels. So if the level of free T4 is either normal or it is high, we call it as a hyperthyroidism. And if the TSH, if the free T4 level is low, we call it as a secondary or tertiary hypothyroidism. So the next lab test include antibody testing. So what are the possible antibodies can we screen? So we have a thyroid globulin antibodies, and we also have thyroid peroxidase antibodies. So majority of the patients with hypothyroidism has a thyroid globulin antibody and as well as thyroid peroxidase antibody positive. And you also have 20% of the cases of autoimmune hypothyroidism where the thyroid TSH receptor antibodies are positive. So other lab findings also include mild anemia when we rule out the blood CBC, the complete blood counts, and also the patient presents with acute hyponatremia and hypoglycemia as well, but that condition is very rare. So when we rule out the lipid profiles, the patient presents with dyslipidemia, and you evaluate the values of creatine kinase. The patient presents with, you can find that the patient has hypothyroid myopathy. So the final one is treatment. So coming to the treatment of hypothyroidism. So the hypothyroidism patient needs lifelong hormone substitution. So what are the hormones we supplement the patient with? So we'll start with the levothyroxine. That is the first line treatment of hypothyroidism. So levothyroxine is actually the synthetic form of T4. So this is considered as the first line treatment. We also have a leothyronin. So this is the synthetic form of T3. But this synthetic form of T3 is considered as a treatment with the part with levothyroxine only for the patients with myxedema coma. So this treatment is not recommended as monotherapy along with levothyroxine for long-term treatment. I hope you guys are clear with the hypothyroidism, its evaluation, diagnosis, and treatment. Thank you for watching. I will give you a heads up on the next video.